Hi everyone, in this video we will talk about rubella and infection in pregnancy. So what is rubella? It is a viral illness that spreads from person to person by respiratory secretions. It is usually mild and self-limiting, but exposure during pregnancy can result in fetal infection and congenital rubella syndrome. That is why we're focusing on rubella in pregnancy or around pregnancy. So who should be vaccinated against rubella? Children at 12 and 18 months. At 12 months they'll be given an measles, mumps, rubella containing vaccine, MMR, and at 18 months they'll be given a measles, mumps, rubella and varicella containing vaccine. Seronegative women of childbearing age should also be vaccinated, but they should be non-pregnant and avoid pregnancy for 28 days after the vaccination. So the contraindications of the vaccine are, the first one is anaphylaxis to vaccine components, 2 is pregnant women, and 3 people who are immunocompromised. Also, it is important to remember that MMR and MMRV are live attenuated vaccines. As for the clinical features of rubella, rubella is asymptomatic in 25 to 50% of cases. In some cases, prodromal symptoms may be evident, such as low-grade fever, transient erythematous rash, lymphadenopathy involving post-articular and suboccipital nodes, arthritis and arthralgia, rarely neurological disorders, and thrombocytopenia. The rash characteristically begins on the face and spreads to the trunk and extremities. It will usually resolve within 3 days in the same order in which it appeared. So face first and then body. Maternal viremia may occur 5 to 7 days after exposure, with spread of the virus throughout the body as well as the transplacental infection of the fetus. The route of transmission is droplet and contact with nasopharyngeal secretions. The incubation period is 14 to 23 days, and the period of infectivity is 1 week before until 4 days after the onset of the rash. As for the infection precautions, non-immune staff should not be assigned to care for the woman. Contact and droplet precautions should be used, which are single room with own toilet facilities, surgical mask, and dedicated equipment. So moving on to the maternal screening, routine antenatal screening for rubella IgG is recommended for all pregnant women at their first visit. All pregnant women who have contact with rubella or clinical features consistent with rubella-like illness should be screened for the presence of rising antibody titer and or rubella-specific IgM. And serological confirmation is required before rubella can be diagnosed. Remember that rubella is a notifiable disease in Australia. So as for the maternal diagnosis, we should start by obtaining maternal history of previous vaccination, and results of any previous screening tests for rubella immunity, such as IgG antibody levels. And it should be above 10 international unit per ml, which is protective against infection. If it's lower, then we need to vaccinate again. Document the stage of pregnancy when contact with rubella occurred. this affects the outcome will be explained later on, and identify duration, intensity of contact. For example, living with a family member with rubella, or a workplace contact over how many hours or days, brief contact only, and the nature of contact. For example, it is close, professional, hugs and kisses involved, so that also matters. Any clinical laboratory evidence for rubella in the contact, and the stage of the pregnancy when clinical rubella occurred or occurs in the mother. Also, features of clinical rubella in the mother. So that's the history that we need to involve. So now I'll explain to you what the presence of each immunoglobulin will mean. So remember that the IgM is the first antibody the body makes when it fights a new infection, which indicates an acute infection, while the IgG can take time to form and means there's a previous infection or immunity. So if both are positive, it means that there is a possible recent infection or reinfection. We should also repeat tests to confirm. Positive IgM and or increase in IgG, it means there is maternal rubella infection. Now, in the case of negative IgM and negative IgG, it means that this person is susceptible to rubella infection because there's no immunity, no IgG. We should also repeat serology if it's been less than 3 weeks since contact with the rubella infected person or less than 7 days since onset of illness. After we repeat the test, if there is seroconversion, it means this is maternal rubella syndrome. If not, it means that this person is rubella susceptible and should be immunized after delivery. As for the case when IgM is positive and IgG is negative, it means that this is a possible recent infection. We should repeat serology. Now, if seroconversion occurs, it means that this is maternal rubella syndrome. If not, it means that it was a false positive IgM, and we should immunize after delivery. So now let's move on to the last case where the IgG is positive and IgM is negative. This means past infection or immunity. Counseling in case of seroconversion. We should counsel women regarding the risk to fetus in relation to timing, and a termination of pregnancy should be offered if maternal infection occurs in the first trimester. We should also consider fetal testing if maternal infection occurs in the second trimester. And maternal infection after 20 weeks of gestation is rarely associated with congenital rubella syndrome. So the maternal management of rubella depends deeply on the timing of the infection, of the maternal infection. So, for example, if the maternal infection is in the first trimester, then both the rate of fetal infection and the risk of congenital defects in the fetus are very high, which are 80 and 85% respectively. While as we go through the pregnancy, the risk of congenital defects lowers until it's very rare in the third trimester, if the mother is infected in the third trimester. As for the rate of fetal infection, it lowers until we reach the last few weeks before birth. If the mother is infected in the last few weeks before birth or in the last week before birth, it can reach up to 100% rate of fetal infection. So moving on to the postpartum management. So what we should do is vaccinate women found to be seronegative on antenatal screening before discharge with measles, mumps, and rubella vaccine. And if the rubella IgG is less than 10 international units per ml, or for women who were born in Australia or Western countries if the rubella IgG is between 10 and 20 international units per ml. They should also have a second MMR 4 weeks after the initial dose. We should also inform the women to avoid pregnancy for 28 days after vaccination. The anti-D immunoglobulin does not interfere with the antibody response to vaccine. If anti-D immunoglobulin is also required, the two may be given at the same time in different sites, with separate syringes or at any time in relation to each other. So let's move on to fetal diagnosis. Rubella PCR, culture, and fetal IgM can be performed following chorionic villus sampling, CVS, amniocentesis, or choreocentesis. Antenatal testing is recommended at least 6 weeks after known maternal infection and is best performed after the 20th week of gestation. So now let's move on to the amniocentesis. Remember that amniocentesis is done usually between 15 and 20 weeks of gestation. In rubella, it should be done 3 weeks after symptoms or estimated time of a subclinical infection. Amniotic fluid is cultured for rubella virus. Cultures are maintained for 8 weeks before considering a negative result, okay? A negative culture does not completely exclude fetal infection. The likelihood of a positive culture falls rapidly after the first few weeks of culture. As for the fetal blood sampling, we should consult with a fetal-maternal specialist for consideration of fetal blood sampling. It is usually done 21 to 23 weeks, and rubella-specific IgM antibodies and ethylenediamine tetra acetate EDTA anticoagulated blood is cultured for virus isolation. A negative IgM titer does not completely exclude fetal infection again. So moving on to the chorionic villus sampling. Just a reminder, chorionic villus sampling can be performed between the 11th and the 14th weeks of gestation. It may be considered occasionally in the first trimester when couples are not comfortable about termination of pregnancy based solely on the high risk of fetal infection and damage. It is associated with risk of contamination with maternal tissue, which gives us false positive PCR results. So now let's move on to infant management. We should ensure all clinicians caring for the newborn are rubella vaccinated and have specific antibodies detected. We should also have a pediatrician at delivery, and newborn assessment should include physical examination for evidence of congenital rubella syndrome, which are growth restriction, cardiac abnormalities, rash, hematological abnormalities, pneumonitis, and osteitis. So the investigations that we can do are cord blood IgM serology, heel prick test for IgM serology, maternal blood for IgG and IgM serology, PCR for rubella through urine and pharyngeal swabs, urine and pharyngeal and conjunctival swabs for viral culture. We can send placenta for histopathology, and the results can take several weeks. So the infected infant would usually have IgG greater than maternal IgG titer, and the IgM would be positive and the PCR would be positive. He can be symptomatic and asymptomatic. Remember, we should always do supportive management if the patient is symptomatic. We should do serial follow-up for both symptomatic and non-symptomatic babies, and they should get ophthalmology, cardiac, and hearing assessments following birth. So that's it for this video. I hope this video was helpful for you. If it was, please like this video, share it with your friends, and subscribe to my channel. Thank you so much for watching. I wish you all the best. Thank you.